so many areas of life, of work, where you will encounter this. And so I thought just having kind of a generalized idea of what this entails is a really good idea. Prime scenario, you work in an ER and the ambulance brings in a patient after a multi-vehicle MVA. The patient is unconscious and you realize he has a prosthetic leg. You need to evaluate him for a knee injury but cannot access the knee because he's wearing a prosthetic leg. You have no idea how to take that thing off. Awkward. Who wants to try and take my leg off? I'm dead serious, guys. Yes, come on. Hold on, if you already know it, don't cheat.
I don't know how
okay,
to
come
do
on. Don't hurt me.
Zero clue.
Definitely not just pulling it off.
I think you should just yell it.
Ow! Just kidding. Nope.
Nope.
Please don't twist, I have patella in there.
Okay. Yeah, no clue.
Oh my god. I think my blood pressure is going down.
This will call someone else.
Oh no, it's going downhill. What code is going to happen? You can literally hang me upside down on this. I could go bungee jumping and this wouldn't come off by pulling on it. Very secure. Not to your advantage. No. Anybody else? Nope. Guys, I'm crashing.
Hey, I.
No, but you have the right approach. I do? Yes. Not with the location, but with what you're doing.
Okay. There's like a lot of bumpy on the
So think about it like this. When I scratch my leg like this, I will not be taking my leg off. However, if I had a leg on that side, it'd be causing trouble.
There's a circle. There's
A circle on the...
There's a circle on the outside of the leg towards down.
Do it
right here.
Here.
Yeah.
I think there's release.
Oh.
She freaked a little more. No, you gotta push it more. She did it! Okay, so there's a pin lock system in this leg, and that's what keeps me in. So you can come up front later after the lecture, and you can look at all these different locking mechanisms and and everything up front. But so there's a hole in this leg. There is a locking mechanism on the lateral side of this. You can kind of see me pushing in here, and basically what it does, it releases this thing that kind of clamps around this pin. This is in my liner, not in my leg. So no pain associated with it. It's just a liner that has kind of a gel material on the inside. That way it does not slide. It's airtight on the inside. It doesn't go anywhere. You can pull on this. But it holds on the leg just perfectly. And it's comfy. So that's how this leg is attached. I did bring my running leg, and I think I wear wide enough pants that I can put it on later. And so you can see how that attaches. And that's actually with a valve and with an air. But basically it's airtight. It's a one-way valve, and that's how it stays on. Okay, so now you know how to save someone. All right, so what are we going to talk about today? How does it happen? How do you become an amputee? What are the different procedures in case it is traumatic or in case it is through sarcoma or something like that? What are the different classifications of prosthetics, of amputations, and then what now? What after the amputation? Because what I've encountered a lot of times is as orthos who do amputations, they just think that they cut, they close, the process is done. But really, if you don't have an idea of what comes afterwards, what kind of a residual limb is required to have proper prosthetic fitting? What is the wound care afterwards? What referrals do you need to do to wound care, to physical therapy, that kind of thing? You're not going to be a very effective provider. So that's kind of what we'll talk about there. And then what does life after an amputation look like? Can you do sports? What activities of daily living do you need to think about? Can you work afterwards? So all of that. And obviously by me sitting here, a lot of those questions have been answered. All right, so how does it happen? Well, your mom told you to wear socks, so it can be like that. Obviously infections can happen. Traumatic. And name the tumor. Anybody? Very good. What do you call that finding? No, sunburst here. That's actually board stuff. I mean, that'll come with other ortho stuff. You'll learn that. All right, or congenital. So this little guy competed in the Endeavor Games. Have you guys talked about Endeavor Games? No. So I competed there for years. It's really local. It's up in Edmond. Usually UCO hosts it, but it's usually on the Edmond North track. And he was born like this, and he usually competes in track, 40 meters, 60 meters, 100 meters, 200 meters, 400 meters, long jump. Probably would do high jump if they'd let him. He does swimming and archery. Like, his mom is basically just running for 3 days straight. He's pretty amazing. And then, what does the procedure look like? So, lower extremity amputation. This is the type of amputation that I have had. Is there a pointer on this? Yes. Perfect. Okay, so basically, say there's an infection in the foot or anything like that, they have to decide to remove the foot. This is a terrible idea as far as the residual limb length goes. So say he really just has something wrong with the foot. You're wasting some perfectly good leg right here. The best length for a residual limb below the knee is 6 inches actually, because that is the perfect length to still have a good lever for inside the leg, because that's how I move my lower limb, is by my residual limb being inside that leg. So if that is too short, you don't have very good lever. And you don't want it to be too long, because think about it, there's a foot componentry, then they have to attach some plates and some screws and some, maybe in the future more computerized ankle. And then to attach that to the socket portion where your actual limb is in. So there's a lot of build-up here. If you leave your limb too long, you're not going to have enough build-up space to put a foot underneath it. Stuff you wouldn't ordinarily think about. What they do is obviously they have to sever all the muscles, all the tendons. They have to cut through the bones, and then what they do is they try to seal it all up. And what they used to do a fish mouth procedure. So this is what they did on me. They just cut it straight, left a little longer skin on the outside, and then sewed it together on the bottom. The problem with that is now you stand on this thing, and where you have the most tension is exactly where your scar is. So leaving the scar on the bottom of the residual limb, they've learned over the years, has caused a lot of problems. So over the last few decades, they figure out that this is a much better idea, that you leave a posterior flap that is longer, you close it anteriorly and suture it shut, because you don't ever have any pressure anteriorly inside a prosthetic leg, because that's where your bone is, where your tibia is. So you can't put pressure directly on the bone anywhere, and may as well leave the scar right there. So this has worked out pretty well. You need to consider, and we'll talk a little bit about phantom pain later, but consider what you do with the nerves. You can't just leave it hanging in there. It serves well to cauterize them, to, maybe you need to sever the nerve entirely if there is no purpose for it. So think about, how can you prevent future phantom pain? So it's not just a cut and sew kind of thing. You have to put some thought of the future in there. Upper procedure, so basically we're dealing with the same thing. You still have to do all the different cuts and then close it up appropriately, and for them as well, they need to consider where the scar is, because as far as prosthetics go on the upper limb, the way they move their wrists, their fingers, they now have prosthetics where they move all the fingers individually, so like you can play the piano with an arm prosthetic, theoretically. But the way you move it is there are plates inside the socket of where your residual limb is, and by contracting your biceps, your triceps, by all the different muscles in there, and in different strengths, that is how the prosthetic knows to move certain things. So you can't leave a scar in the middle of where the plate needs to be attached to allow for movement of your prosthetic. And then depending on whether you need to be moving an elbow and a wrist and your fingers, or if you have your amputation right here and it's just wrist and fingers, you need to consider what componentry you need. Every prosthetic practitioner, I would dare to say in the world, but for sure in Oklahoma City, would love for you to ask questions if you don't know where that placing is. Because how would you know unless you had a prosthetic leg there? I don't know where those plates go. If I wasn't in ortho, I would go do a tour and invite one of the prosthetic practitioners into the surgery maybe even, and say, what do I need to consider here? And just learn some. The Erdl procedure is a different procedure than what we talked about, where you just kind of sever and then use the skin flap. What he has done, and I actually did my ortho rotation with him because I was so interested in this, is that he found a way to create a bone bridge using a fibula bone graft and the tibia periosteum. So basically, he leaves the sheath, the periosteum around the tibia longer, hollows it out, and then he takes whatever he cuts off the fibula, whatever he needs to get rid of anyway, it gets right there in the ER as a cleaning procedure, sterilizing procedure, filtering procedure, and then he takes those bone fragments and basically shoves them into this, the periosteum for the tibia, and then sews that on top of the fibula. So there's this kind of like sausage that he's created that is attached to the fibula, I mean in effect. And then, so it's a much longer recovery time because if you think about it, all of that has to now mineralize. It has to become bone again. And it has to fuse together and it has to build a stable enough bridge so that, which is the end goal of this procedure, you can do end weight bearing. So right now, if I was to take my prosthetic leg off and I would try to put weight on the end of my tibia, it'd be excruciating pain. I can't weight bear on the way my amputation is done. But for them, because it's kind of like having a heel on the bottom of your residual limb through that bone bridge, they can actually bear weight, which is a lot easier when this works for prosthetic fitting, because for me it's really finicky. I can only tolerate weight on like lateral and medial to my tibia, and then there are a couple posterior spots and a couple lateral spots further down where they can make pressure points to keep my weight on, otherwise I get pressure points and I get sores and things like that. So it's really tricky to build that. For them, they could literally step in a bucket and be okay, because they can bear their weight on the end of the prosthetic, so you don't have to worry about all these little intricate pressure points. The tricky thing is, like I said, there's a longer recovery time. You really have to hone in on your patient and say, do not step on this too soon or you are ruining it. Because it's tricky, you know, if you had your leg amputated for whatever reason, your prime goal in life is to be walking again, usually. I mean, at least if you're a certain age group, you know, a certain activity level. And so you really have to kind of hold them back and get them final approval. And then this fails a lot of times, even with optimal recovery and optimal everything. So then you have an even shorter residual limb because they had to use quite like an inch of bone from tibia and fibula to make this bone bridge happen. And now you don't have this anymore and your bone bridge failed. So you really only have like 1 or 2 attempts at this at best, and then you're kind of running out of residual limb if you still want to be below the knee amputee. So these are the classifications, speaking of below the knee amputee. The lowest you can be is a foot, have is a foot amputation. There are prosthetics that allow you to basically slide into almost like a shoe, and the shoe is a foot shape. So if you still have, say you're all the way down to your heel and you just had like a 4-foot amputation or something, you would slide into a foot-shaped thing, which is your only prosthetic. But if you have an amputation that you think is going to be right above the ankle, please don't keep all of that. Remember, like we talked about, you have to think about what componentry needs to fit underneath that. And you have to have that conversation with the patient, because they'll be like, what do you mean you cut off more of my leg? And so that just doesn't seem like it's very logical. If it is directly like through the tibia, it's called transtibial. Logically, if it is directly through the knee, so you're keeping all of your femur, you're making a clean cut right underneath that, it's called a knee disarticulation. Similarly, if it's straight like above the femur, it's called a hip disarticulation. And then transfemoral if it's straight through the femur. So they're very straightforward. And similar with the shoulder, so there's a shoulder disartic and there's a wrist disartic, and there is a transradial, there's a transfemoral, and a 4-quarter amputation. This is tricky for prosthetic fitting because you know how I was saying you need all of these different points to then move the limb. So now you have a shoulder joint, an elbow joint, a wrist joint, and the finger joints all to move, and very little attachment points. So these people usually don't actually wear prosthetic. Same with these people. Hip disartic, there are very, very few hip disartics that actually wear prosthetic because it's a very heavy thing to wear. It has to be fitted around the entire waist, so they wear an entire waist thing to fit that. And then it is semi-successful whether they can walk smoothly on that. All right, so questions so far? All right, so now, what now? Say the amputation is done, these people come back to you, you do your post-op, everything looks good. So wound care, anybody know what this thing is called? Wound vac. Exactly, so this comes in really handy, especially if it was a traumatic amputation, because if you're not entirely sure that this thing is going to be infection-free, you don't know how contaminated it was, it's a really good idea to leave an opening in there, and then just let it slowly close over time. The other thing is, if you only have very little residual limb, and you need to, you can't immediately close it because there's simply not enough skin, or because there's still too much edema in there, this will let it heal over time, and you can then close it afterwards. It takes another procedure, but it's really quick at that point. The ice cubes are there because one of the most memorable and useful things that was done for me after my amputation was ice cube therapy. I'm not sure they called it like that in German, but so what they do, what my mom ended up doing is basically on my fresh incision, you know, where they just closed it, she took ice cubes and she rubbed over it. And it was not a fun thing, it was not a comfortable thing, but it's desensitization. Basically, you're trying to make the skin tougher there, because it's going to have to stand a lot of pressure, and it's going to have to stand temperature and different contact. And it's a skin area that right now is very, very sensitive. So the more you can desensitize the area, the better it is. I've heard people say take an exfoliating glove and go over it with that, you know, just gently, anything to kind of desensitize the area. I usually bring an A-strap, and I forgot, so you got lucky. But there are a couple ways of, I usually make you do this too. There are a couple of ways of ensuring that there's enough shrinkage. And so what happens is, if you just had an amputation, there's a lot of swelling in there. And so you can't fit a prosthetic on a limb that is really swollen. I mean, you need the recovery time anyway, but think about it, if so this is my residual limb, you know, everything is healed up wonderfully, but this thing is hanging down all day long, where's all the fluid going to go? So it is going to be swollen. If they are building me a prosthetic on that size limb, and then there's not pressure around it, there's a liner around it, it's going to shrink, and my leg is within hours not going to fit me anymore. So to assure proper fit, they need to wait enough time that everything is well healed, and then they need to make sure there's enough shrinkage. So there are actual shrinker socks, like this down here, and they're like compression stockings. They're exactly like that, they're just made for residual limb. So they're really, really, really tight. You want to put them on first thing in the morning. You want to put them on gently because it is a sensitive area. And if you see, I mean, they try to make comparison here. See how wide this is, and then with the shrinker it just becomes more uniform. And then this, we call this, they called those wheat grain wraps because it looks kind of like a grain of wheat with it being like this. But basically, so you wrap it around the front, secure it one time around, and then you go left side, right side, right side, if that makes sense. You just kind of go around figure 8. And then close it up top. And you want to be sure you end above the knee, because if you end below the knee, there's just too much swelling right there. And think about the prosthetic goes all the way until it has those ears, you know, that go above the knee. So you want to go and make sure you cover the entire area where the prosthetic is going to be. And then physical therapy. Personally, I remember being in physical therapy for years. And granted, it's a different healthcare system. You know, there was none of my own cost associated with it. But I would dare to say, if you would see me walking down the street, you would not be able to say that I am prosthetic. It's really important to me that, I mean, you see my kind of legs I have. I have bright, I have bold legs. I have the kind of leg that has like a funky, you know, cover on it. I wear shorts and I wear skirts, whatever. But there are people for them it is really embarrassing to have a prosthetic leg, and they would rather hide it. And you can't hide it when you're limping around. And it impairs your quality of life. Aside from the fact that when you have a limp, that means you have an uneven gait, which means it is going to be bad for your back and for your hips and, you know, for everything up. And so to prevent further complications, it's really important they have a smooth gait. Send them to physical therapy. They need to learn how to, for lower extremity, walk stairs, walk up and down a ramp. Stairs were nothing compared to walking down a ramp. That is the most difficult thing. Because that decline, you know, I don't have an ankle. I can't plantar flex my foot. So I have to learn how to walk down a decline with a 90-degree flex foot that is stiff. And then for above, like for upper extremity amputations, think about closing buttons and, you know, tying your shoe and all those things, wiping your bottom. I mean, there are so many things that you don't, in your everyday life, you need your arms for. One of the things, like amongst amputees, there's always like, I'm glad I'm a foot amputee, I'm glad I'm an arm amputee. I mean, there's like, I'm better off than you are, no, I am better off. It's ridiculous, but I can truthfully say I don't know that I feel blessed to only have a foot amputation or below the knee amputation, because there are so many more difficult scenarios to me if I didn't have my hands. I feel like that'd be more imperative. That's just my personal opinion. And then, I mean, there's the actual in a building physical therapy, and then there's things like aquatic therapy, and especially in the very beginning stages after an amputation, that is a really good therapy to do. And again, for upper extremity, what if you're a kid and you want to just play Legos again? I mean, it's simple things.
Are they waterproof? Like, can they swim with them, or do they have to keep them?
Great question. So, they would probably want to take it off. So that's why the aquatic is probably more for directly after the amputation, for them to gain their balance again and all of that. This one is my water prosthetic. I'm super spoiled, guys. Don't take this for granted. Because it has the most simple componentry and it is almost rust-proof, except for this screw right here, which is rusted because I was in the ocean with it. But it's basically the most simple componentry. It has no locking mechanism. I just slide in and then I wear a sleeve over it, and so that's how it stays on. And that's the only way I can go in the water with it. But even with that, now think about if I have air and that what happens when I'm in the water. I have a buoy after me. And what if they make it too heavy? Now I have an anchor on me. I mean, there's just no winning with this. So I have learned to swim. I lost my foot when I was 5. And I learned to swim without my prosthetic on, and I find it very hard to swim with a prosthetic because it's an obstruction. I move much better without it. I have a very good friend who's a double above the knee amputee, and she also swims without any prosthetics on, because for her, she's much lighter in the water, that way it's much easier. She just uses her arms instead. So yeah, good question. So, talking about phantom pain, 60 to 80% of amputees experience phantom sensations in their amputated limb. So mind you, it's phantom sensations, not just pain. And the majority of the sensations are painful. Phantom pain occurs within a few days of amputation in 75% of patients, but can begin months to even years later. They're usually neuropathic type pains, so you know with neuropains it is a cramping, shooting, stabbing, or burning type pain, rather than like throbbing, which is usually more vascular. So think of the neurotype pains. This also means if you were to think medicine, think neuromedicines, right? So neuropathic pain medicines. But that's not where we want to go right at first, because that's a dangerous thing to slide into to try and medicate your pain away. So I'm not sure, I mean, does anybody watch Grey's Anatomy anymore?
Oh,
okay, so has anybody seen this episode right here where she had her amputation and they're trying to calm the waves in that episode? So what she does, she basically tries to do, it's almost like meditation, where she just imagines to calm the waves. So the waves are the pain, and the harsher the waves are, the worse the pain is. And so she's just trying to, like the imaging, to calm the waves. And then the other thing is, it's really, I'm sorry if you can't see that very well, but you have it on your screens anyway, right? Yeah. So you can do artificial visual feedback, where you basically, yeah, sure. Where you basically put a mirror so that you can see the sound size times 2. And so you trick your brain into thinking there are 2 sound sides, there are 2 unamputated legs. I cannot from personal experience tell you what of this works, because I'm one of those extremely, extremely lucky people who do not have phantom pain. There's a theory, I don't think it's proven, but it proves true in many instances that when you've had an amputation before you hit puberty, you're a lot less likely to have phantom pain versus if you had an amputation post-puberty. And so yeah, I got lucky. The only phantom anything I have is if you tickle the bottom of my prosthetic foot, it tickles me. Only if I see it, obviously, but it's the weirdest thing, it really does tickle. And then every now and then my little toe itches, which is the worst because there's nothing to scratch. So then basically I have to take my leg off and find which nerve that is and just kind of go at the area, and then that's okay. TMI, sorry, but that's the only way. There are other things. You can do a massage, you can do cold packs. Exercise is known to help, actually. neuromuscular stimulation by external electrical currents, so like stim machines, you know, like they have in physio, that kind of thing, acupuncture, and regional sympathectomy. So basically that's how I was saying earlier, sometimes it's smarter to just take the nerve away. And sometimes you have a neuroma too, so then if you can pinpoint where their pain is and you can actually show that there's a neuroma, you can turn their life around by just taking the neuroma out, like scheduling surgery, take that out, because then it won't hurt anymore. So keep that in mind as well. So as far as medications, if you need to go in that direction, again, it's a neuropain reliever, so gabapentin, amitriptyline, carbamazepine, and but I have, I know a girl that has become addicted to painkillers post-amputation, and it is way worse than her amputation. And prosthetic care, of course. Are those not the cutest? So this is actually a prosthetic hand. Does it not look freakishly real? There's a company in Dallas that takes latex basically, and they want pictures of, they prefer that you come down there, but if you can't make it down there, they want measurements and pictures of your sound side, and they make an identical copy of your sound side, just mirror image of it, including the redness on the knuckles, the hair on the fingers, the nails, with any kind of like dents they may have in it, and all of that. Same thing for feet. It is so cool. And then, I mean, even here in the city, they have the ones where, you know, where they shape it and they spray paint it to be your color, and it matches the color. I usually get my legs done in summertime, so I'm nice and tan, but in winter you wear long pants anyway, so it doesn't matter, my left leg is brown, my right one is not, right? Gotta think these things through. As far as above the knee prosthetics, so they're very basic hydraulic prosthetics, where it's the normal hydraulic oil-based joint system, and the way they swing out their knee is by just swinging it. So, and then on the way down it bends because, you know, it falls again. You cannot have a smooth gait with that. There's just no way. And then the newer ones are all computerized. You know, there are C-legs, and they're the newest types, where it used to, they were just kind of like helping with basically putting a brake on extension so that it wouldn't just flop out. But now they actually help you go up the stairs. So there's a motorized component in it. So now they can walk stairs alternating. So my friend with the double above the knee prosthetics, she has one that's really short and one that's kind of a knee disortic. So she used to have to go up the stairs like this, because you can't, I mean, even if she'd swing her leg, she's still on a wobbly this side. Now she can actually go up the stairs alternating because the prosthetics do the flexion extension for her. It's so cool. And then this is, remember how I was talking about upper extremity? He actually has the forequarter bilaterally, and they managed to have a shoulder joint, elbow joint, wrist, I mean, all those joints in there. I would love to know who that is and see if he uses this prosthetics, because that would be super impressive. I'm sure somebody's out there doing all that. And then you see how this is just a partial prosthetic, how actually like the fingers are prosthetic, but he still has a similar thumb right here. And this is my little guy again. Anybody know who that is? He's made a name for himself, but not in the
Is that the prison?
yeah. He got out?
Where is that?
It's possible. I don't know. Yeah, he's from South Africa. It's Oscar Pistorius. So he got famous because he actually competed in the Olympic Games, not Paralympic, but Olympic Games. Because he qualified, he was fast enough with his double prosthetic to compete in the 400. And there was a lot of controversy around it, because they said, well, the only way he's so fast because you know, he just is on his pogo sticks, and so he doesn't really have to use his muscles. And then he was like, well, here's your counter study that shows how much more effort it takes for me to get going, whereas you can use your muscle. I just don't have the muscle fatigue on the end, but it doesn't come out. So there was this muscle fatigue versus a use of muscle right out of the blocks and all of that. It was really interesting. This was when I was still actively running that all of this was, you know, really hot. And then he killed his girlfriend, so that's how he became also famous in a really sad way. It was really bad. So, yeah, it was awful. And apparently he just got out of prison,
Something happened in the news recently. I don't remember what.
which would have been incredibly fast if that is the truth. And I mean, he sat in prison for what, 5 years? And this, I mean, you can do, the sky is the limit. You can do snowboarding. I mean, there are people rock climbing. I mean, everything is possible. They have special bike prosthetics, see, that hook into the bike plate. You can do bodybuilding with this. You can do football. I mean, it's really, really cool. The sky's the limit. So don't ever talk about limitations. Just find more abilities. You find, I mean, the sky's the limit. If your patient comes to you and says, I want to do that, your answer is, I will help you. I mean, I just hate when people have that attitude that, oh, I'm sorry, hon, but you're never going to be able to do that. Back to my friend with the double above knee amputation, she was pushed in front of a train in Germany. So that's how she lost her both of her legs. And they told her, well, you'll probably never walk because 2 prosthetics is just too much. You'll be in a wheelchair. And she was an athlete before. She was a long distance runner before. And so, I mean, just lost all hope. And then she started training. And long distance doesn't really exist much in Paralympics yet, so she just started training for sprints and long jump, and her coach in Germany told her, okay, well, you've reached your limit, you can't go any faster than this. And then she came over here and trained with us and obliterated her personal best. And she kept saying things like, oh, I can't do high knees, like high knee exercises because of my prosthetics. And we'd be like, well, then that's all you're doing today until you can. And so she did high knees. And she did all of these amazing agility drills that people with 2 sound legs have a hard time doing. And so it's pretty mind-blowing. That's why I'm saying you've got to go to the Endeavor Games at some point, just to see that. Think of activities of daily life, what all you need to do. I mean, people need to work, truck drivers. I'm sure what this guy's doing. Definitely don't know what she's doing. But see, you can wear high heels. And he's playing soccer with his buddy, so lots and lots of cool things. The foot, actually this one too, that way I can wear it here. But see, this is actually a high heel foot too, so you can push this button in at the ankle. And then you can make it, and this one is probably maybe 1.5 inches, maybe 2. And then this one I actually had them set, so I wanted to wear 2-inch heels. It's not asked too much, right? And so I had them set this one so it's actually at rest a little plantar flex, so that by max plantar flexion is at 2 inches. So you can play around with it, you know, as long as your practitioner is okay with it. Okay. This is my friend I was talking about, actually. So this is her on the track, and this is her doing long jump, and that was in London. So she is, so this T42, that's how they define, you know, which class you're competing in the Paralympics, because they can't let an arm amputee run with a below-the-knee amputee and with a cerebral palsy, person. So it's just not very fair. So they have these disability classes that you will be in. Any questions so far? So I have a video. Oh gosh. There's no video on yours.
The picture's just covering it.
Yeah, on the next slide, before this one, it's covering it.
There's no next slide here.
That one.
No,
That
the previous one and this one. That one.
There's a video on this.
It's underneath the picture.
Slideshow and then you can move the picture.
Yeah.
Oh, that's weird. I hope that thing is still active. Otherwise, I will go downstairs and I'll get my USB.
Because that said it's not the black.
YouTube.
I just wanted to show everybody and prove everybody wrong that I could go out to the Paralympics and I can go out there and break world records 15 months after my accident. From losing my leg, I just wanted to run track again because I knew I could go out there and do something amazing with it. I felt so strong in life that I knew I didn't lose any speed from when I was in college running track. I knew I was still just as fast.
Jim Bob Buzzell of the U.S. in his first Paralympics. He really didn't even know much about the Paralympics. Back in the spring of 2007, he was focused on a college football career. And then one day, it all changed.
I was riding a friend's bike and just having fun, riding a couple of wheelies, and the bike just came right up in my face. I decided to jump off the bike and I dragged my foot on gravel underneath my body and it just mangled my foot. Once I got to the hospital, they said they were going to take it 6 inches below my knee. I had high hopes about it. I knew I was still living. I was in a motorcycle accident. The only thing I lost was my leg. I didn't lose my life.
I was 5 years old. I didn't care. I didn't think about, will I find a husband or a job. I just wanted to be able to run again. I lost my leg when I was 5 years old in a farming accident. I remember bits and pieces. I was passing out right when it happened, and then I remember waking up again, raising my head and seeing my foot about 2-3 yards away from me. I guess it's an additional challenge to see how far can I push it, how fast can I really go.
I lost my leg in a lawnmower accident in 1991, and I was 5 years old at the time. I played high school volleyball. A opposing coach saw me play and remembered me standing and recommended to the coach of the USA women's state volleyball team that I should come and try out.
10 years ago, I was in a boating accident. Propeller caught my left leg below the knee, and the doctors had to amputate it. The first place I ever went to actually told me that I would never play sports again, and that I would never run, and I would never do anything like that. I was determined to do all of that since I was being told I couldn't do that. But I just knew that's not the way it was going to be. I knew that I was going to figure out how to do things again.
When I was born without a fibula bone, which is fibular hemimelia, and the best option for my case was to amputate my foot. And I've been wearing a prosthetic ever since.
Truly amazing when you think about this. Only 17 months ago, he's laying in a hospital bed, and here he is today.
I went to Okinawa, Japan 10 days before the Beijing Paralympic Games started. That's when I actually started running and started training for the games. I didn't compete to the end of the game, so I had to.
Going to the Paralympics is the reason why I'm doing this and why I'm working so hard. When everybody's cheering for you and you feel like you're the center of the universe just for a couple seconds, it's the greatest feeling. I don't think I am disabled because I can do everything that anybody else can do and a little bit more.
Reach for your goals. I mean, nothing's, too far, out of reach.
I know that everybody has different experiences, but, anything's possible if you believe that you can do it.
Possibilities are endless with any disability or amputation. If you're into swimming, if you're into rock climbing, any sport in general, you shouldn't put a stop to anything that you're passionate about ever, just because of a disability.
Okay, that is that. And that is all I've got for y'all today. I told you it wasn't going to be long. Okay, yes.
So what exactly do you do with the limbs? What do they do, like
like for your leg or?
They cauterize them, so they sever them and then they cauterize them. So do you mean me personally, or they do a procedure? Yeah, you have to locate them. You have to make sure they don't just curl up, because they'll tend to curl up if you just forget about them. So locate them and then either fix them in place or cauterize the end of it.
How far down do you have to feel right now?
I have complete surround.
All the way around?
Just wherever my residual limb is. Anybody? Okay, well then you can come play. You can mess with any of the legs. Oh, I was going to put this on for you, wasn't I? Alright, let's do that real quick.
How often do you have, like, when you were in the Olympics, are those durable enough to really last through that, or is that really hard on the running legs?
I got a new running leg about every 2 years, I would say. Just because, I mean, they last really well, but what you don't want to happen, when they wear out, they also have less of a spring, so they have less of a return, which means they're not going to be as fast. So for professional purposes, you want them replaced fairly often. And then the other thing is for heavier guys, like my husband is an amputee as well, and his running leg they had to replace because he had one that snapped under him when he ran. And if you're full speed, that's not awesome. Hold on, I meant to get something. Hold on, let me hop over there real quick. This is how we walk around our house at night. I swear my daughter must think the strangest things about this world. Oh, people just hop around on their leg at night.
How often when you're growing do you have to get different size ones as you grow?
So a leg is made of the socket, the top part where your actual residual limb is in, and then there's the pylon, which is, you can probably see it best on this one. So there's then the pylon, which is the build up underneath the socket, and then there's the foot component. And the foot only needs to change if either it breaks or you need a bigger shoe size, because your other side grew. So my socket, I needed replaced anywhere between every 6 months to 1 year, depending on how fast I grew. And the foot about every year and a half or so growing up. I had a couple, what do you call them here, re-amputation I guess, because my tibia actually grew a lot faster than the skin surrounding it. And so eventually the tibia caused quite a bit of pressure on the skin that eventually would have come through. And so they had to re-amputate the tibia twice to shorten it. I think once when I was 7, once when I was 9. And my amputation was through a brush hole mower on our farm. Grew up on a dairy farm. Alright. So I put on a different liner that does not have a pin in it, because this leg doesn't have a pin lock system on the bottom, so I would just be sitting on bottom with the pin. And then the sleeve goes over it because the sleeve maintains the vacuum. There is a tiny little hole in the bottom of this prosthetic that leads to a tiny little hole on the outside, and there's a one-way valve in there. And so through that, all the air can escape from out the leg, but it can't go back in. And so it's through vacuum that the leg stays on. So then I roll this up. And, well, usually it has to be on skin, but you know what I mean. And then once that is on, I can really just hop on this. That's pretty cool. I mean, it allows for just much faster. But you see, you can't see this, but I have to be on tippy toes on my right side for me to be even with the hip on the left side. Because in full, first of all, you don't sprint on your heels, you sprint just on your toes. And then in full sprint, it compresses so much that it'll be even to my right side when I'm in full sprint because of the compression. So the fitting of the sprinting prosthetic is obviously fundamentally different than of the normal one. And I have one at home. They have actual plates, like spike plates that they can attach and laminate to the bottom of this. Mine looks way more ghetto with duct tape and a half shoe. But we don't live on the track. And unless I want to drive to the track for every single workout I do, I need to be able to switch between a tennis shoe and a spike. So this way I wear my spike on the right, I cut the left one in half, and I duct tape it around this leg and it works just fine. So that's how it worked for me for a decade, and I did okay. All right. You're good. You can come up front at any time or ask more questions. You just let me know.
Thank you.
Thank you.